All right, so with renal, start off the day. At different points in gestation, various organs are embryologically developed. No surprise there. You should be familiar with that. For example, the notochord. Notochord kind of starts actually at about 2 weeks, pretty much wraps up at about 4 weeks when I know my discs are starting to form. And isn't that the beginning of the teratogenic period? Yes. Brain at 4 weeks. Well, I hope so, because I need brain function for autonomic function for different parts of the body to respond. And ultimately, I have the renal system by 12 weeks. All organs are formed by 12 weeks, folks. All organs are formed by 12 weeks. So, how are they going to go after this in the kidney? Oh my goodness, that word I hate. Metanephros, mesonephros, uteric bud. And we have a hard time knowing what it is. And it's just a long word that I'm memorizing that I absolutely despise. Well, it's really easy, this word. Metanephros gives rise to the kidney. The uteric bud gives rise to the entire collecting system. So if I'm talking about the metanephros, I know it's the cortical region and maybe even a portion of the medulla of the kidney. The uteric bud being the collecting ducts, that must mean it's the calyces, the minor, the major calyces, the pelvic region of the kidneys. Again, these are the portions that must be together. So on the bottom there, I have the uteric bud must make contact with the metanephros or the kidney will not develop. Folks, if the two do not touch during embryogenesis, they will never, ever develop. The kidney will not develop. If the kidney does not develop, we obviously call that renal agenesis. What would the mom present with? Oligo, right. Oligohydramnios. Oligohydramnios. Now, I just threw a picture last night real quick for you, just to give you what metanephros is, what the uteric bud is, where I would find the renal pelvis versus a calyces. It's just the region, okay? Remember, the uteric bud must touch that metanephros. They have to touch for the kidney to develop. If they do not, again, renal agenesis. Take a sidebar here real quick for a second. You said oligohydramnios. That's based off of amniotic fluid, correct? Sure. And what if there's too much fluid? What do we call that? Polyhydramnios. Based off of oligohydramnios and polyhydramnios, what's the normal range for AFI, amniotic fluid index? 5 to 20. Some books say 25, but 5 to 20 is fair. All right, based off of that, do you guys know how they even derive that? How they come up with an AFI? Versus memorization? No dice. Let me just show you so you guys aren't memorizing things. Here's mom's belly. You divide it into 4 quadrants. And you turn around, and we said normal AFI should be 5 to 20. What we do at this point is we take an ultrasound machine and we run it over each quadrant. So as I'm running it over each quadrant, what I'm doing, if I look from the side view, and here's mom's belly, here's the kid, what I'm doing with the ultrasound machine is I am measuring the deepest pocket I can find in that region, and we measure that in centimeters. The deepest pocket, I'll go past the shoulder, under the arms, I'll look for the deepest pocket, measure that in centimeters. So maybe in this box it's 5, maybe 5 over here, maybe 3, maybe 5. This person has an AFI of 18. That's what that is, folks. When you see AFI, amniotic fluid index, that's what they're doing. They're measuring each pocket. So we said that polyhydramnios is a higher number. What's the most common cause? Now, most common, I said. Most common cause of polyhydramnios. If it's a mother problem. Diabetes. What happens to the kid? Macrosomia. So if I turn around and I take this kid and I make him huge, wouldn't that raise mom's belly even more? Wouldn't I have a larger number in centimeters? That's what happens. That's how I know when there's polyhydramnios. If it's a fetal problem, maybe the kid's not swallowing, maybe it's a neurological problem, fluid is building up. It's going to make that measurement even higher. Do you understand? If that kid does not have kidneys, renal agenesis, because the uteric bud did not meet with the metanephros, the kid's not urinating out its 20%. See how the fluid level is going to go down? And when the fluid level goes down, that measurement's going to be smaller, and therefore we have an AFI less than 5 oligohydramnios. And let me ask you this. What do we call the syndrome if the mom? What is it? Potter's. And how do I know what Potter's looks like? Flat face. They were chasing a parked car, right? Smack! Right against that. Their feet start to curve in. Why? Because they're taking the shape of the uterus because there's no fluid there. That's Potter's syndrome. AFI. Okay? Everybody understand that now? That's all it is. Not memorization. Understand the test. Yes?
With the AFI, it's based on single child, right?
Absolutely.
What if there are twins, then how does the number differ?
Okay. It gets a little, we don't follow necessarily the 5 to 20 based off of that. We run other tests to look at each fetus itself. So when we start getting into twins, multiple gestations, I expect polyhydramnios. Based off of that, there's a different set of criteria, far beyond what you need to know right now. But, I mean, it's a valid question. Very good. So this is for single gestation. Okay? Good. They'll never do that to you on the boards. If you're doing OB boards, maybe. All right. Ooh, the other word I hate. Mesonephros Wolffian ducts give rise to genitalia of males. This is another term that everybody seems to hate. Mesonephros. Now, develops into the testes, seminal vesicles, vas deferens, and epididymis. And as you know, there must be a Y chromosome or MIF. Where does MIF derive from? What cell? Sertoli cells. Very good. Sertoli cells. MIF is derived from there. So obviously, if I have a problem with my Sertoli cells, I not only have a problem with MIF, I also have a problem with spermatogenesis, which derives from the Sertoli cells. Remember, testosterone is derived from the Leydig cells. So based off of this, the corner, the box up here is probably the most important in that slide. It says, has kidney function prior to kidney formation. Has kidney function prior to kidney formation. So the mesonephros acts like a kidney prior to kidney formation. And if you look at the slide, you can see the uteric bud. You can see the metanephros. Mesonephric duct is basically the diverticula of that is the uteric bud. But the bottom line is, before those are functioning properly, as you can see there, the mesonephros functions as a kidney. Board question. Now, if I look at the paramesonephrics or Müllerian ducts, if you notice, it's right in the middle here. This is in both sexes in the beginning, right? Both sexes in the beginning. The difference is that the paramesonephric does not function as a kidney. The mesonephric does. Okay? Develops into the ovaries, fallopian tubes, uterus, and upper vagina. And remember that females are developed either by design or by default. One or the other. All right. So then I put an embryonic picture in here of terminology that you're asked a couple times on the boards. Maybe it's the Ventolin duct. Maybe it's the allantosis that you've heard before. Maybe it's the Coloca, which is the bottom portion there. Bottom line is that when we use these three terms, or you see these three terms in questions or on the boards, different things like that, you must have an idea of what they're talking about. So I put that picture in there just for orientation, and now we're going to go through all three of those so you understand what they do. So the Ventolin duct, as you look or can see there on the top, what actually happens with the Ventolin duct is that the Ventolin duct, also called the omphalomesenteric duct, and so I have my trachea coming down, and I have the lungs starting to form. Stomach region. Going down into the small intestines. And this is the Ventolin duct. And down here is where I would find a cloaca. All right, so if you notice, it's all basically one tube. So if I have a problem with the GI tract, as I mentioned to you in GI, I also have a problem with the lungs. Why? There you go. They're all part of the same duct. They're all the same connection. Now, why did I want you to know this? Why do I want you to know the Ventolin duct? Well, that Ventolin duct itself that comes in to the GI tract, as I have there, is supposed to undergo apoptosis. It's supposed to basically obliterate by week 7. Week 7. Supposed to be obliterated by week 7. But let's say it doesn't totally obliterate, and there's a fibrous band and just a little bit of the duct at the end here. Folks, don't we call that Meckel's diverticulum? That's Meckel's diverticulum right there for you. Meckel's diverticulum. Meckel's diverticulum. How do I know? They're going to tell me there's a fibrous band going to the umbilicus. Or they may say the abdominal wall, but usually the umbilicus region. And ultimately, I know that there's a pouch off the GI tract. Now, question. Is this a true diverticula or a false diverticula? True, because it contains all 3 layers. All 3 layers of the skin. Very good. Allentose. What happens with the allentose? Well, here's your fetus. Comes up. This is your allentose right here. Allentose has blood vessels wrapping all the way around the outside, ultimately making up the cord. And remember that you have the placenta villi. Placenta villi connected to the uterine wall. So let's see, this would be the amnion cavity. Allentose. And the purpose of the allentose is to exchange gas and liquids with the fetus. Purpose of the allentose is to exchange gas and liquids with the fetus. And if that stays patent, that's what we call a urachal cyst. Urachal cyst. How do I know this kid has a urachal cyst? Mom will come in and tell you that little Johnny's peeing from his umbilicus. Little Johnny is peeing, urinating, voiding, whatever word you want to use, from his umbilicus. That's a urachal cyst due to remnants of the allentose. Okay? So Ventolin duct and allentose. Yes?
Strictly from there, or is it both?
What do you mean from both?
Like from the urethra and from there, or is it?
No, you're talking about, the question is it from there or from somewhere else? And the question is, when it's a urachal cyst, it's only from the allentose. If I have esotrophy of the bladder, I have the bladder hanging out. If there's a rupture within the wall, I can leak fluid from there. But if they just tell you, little kid urinating or voiding from his umbilicus, allentose remnants. Okay? All right, moving on. Everybody okay? All right. They can. They have 2 ways, because when I start to squeeze, increase. Question is that can they void normally like a normal child? Yes, but they also have leakage from the umbilicus. Absolutely. Very good. All right. So the cloaca, which is that lower portion of the pitcher, is also called the urogenital sinus, if they're looking at the base of it. The bottom part of the cloaca is known as the urogenital sinus. The urogenital sinus in males is where I get the prostate, prostatic urethra, and the bulbal urethra, otherwise known as Cowper's glands. And in females, the lower vagina and labia majora, or I should say minora. The point is that it's at the base of the cloaca, and that's what I want you to know, the base of that. Okay? Otherwise known as the urogenital sinus. Now, if I go all the way over to the tip of the cloaca, just the very tip, in males becomes the penis, females the clitoris. So again, it's the cloaca, but it's the very tip of it. And again, we call that the urogenital tubercle. The base is the sinus, the tip of it is the tubercle, T for T, tip. Okay? In males, the penis, and females, the clitoris. All right, everybody okay? Folks, that's all there is for embryo and renal. That's it. You guys can deal with that. There's not that much there. You want to go learn more embryo, I'm sure. Don't do it. This is all you need to know. That's all they ask about. Now, a little bit of anatomy. L1, L2. Right kidney is positioned slightly lower than the left. Actual board question. Why? I don't know about you guys, but I don't have Kurtagner syndrome. My liver is on the right-hand side, so therefore it must be a mass effect lowering the kidney on the right. That's all the question was. Get your point, Angelmans, get out of there. All right, the cortex. Well, we have two regions of the kidney, the cortex and the medulla. Cortex, the outer portion of the kidney. God bless you, you know what to do next. The outer portions of the kidney, cortex, outer portions, contains the PCT and the DCT, distal convoluted tubules and the proximal convoluted tubules. Cortical nephrons are shorter in length compared to the medullary and function to maintain isotonic urine. The cortex gets, think about this, how many liters of blood do we have in our body on average? How many? 5. 5 liters of blood. One of those liters, 20%, is going to the kidneys. 20%. 1 liter goes to the kidneys. So if I do anything to affect flow to the kidneys, you can see how we're going to run right into that low volume state, correct? Now, based off of this, of that 1 liter, 90% of that 1 liter goes to the cortex. Only 10% of that 1 liter goes to the medulla. So do you see right off the bat, the medulla is kind of on the edge of hypoxia? If I just went off a surface area, the medulla is much larger than the cortex region, thanks to the calyces and all that region, but it only gets 10% of the blood supply going to the kidneys, or I should say, of the 1 liter. Now, if I'm looking at the medulla itself, deeper layer of the kidneys, pyramids collecting the urine from the collecting ducts and draining into each papillae. From each papillae goes to the calyces and the ureter. Ultimately, what's the response of the medulla? Is to concentrate urine. Concentrate urine. So if I have anything that decreases blood flow to the kidneys, what part of the kidney is going to be affected first? The medulla. And if the medulla is responsible for concentrating urine, then, I don't know, maybe they come in telling you that, maybe excess urine, very dilute urine, because they infarcted the medulla. Papillary necrosis. I don't know, I could throw a ton of names at you pathologically, but the point is I destroyed the medulla. This person can no longer concentrate their urine anytime they're in a low flow state. That's why we worry about it. If I have a trauma patient there, okay, yes, they look pale, they look diaphoretic, yes, I want to get some fluids on board, and you think right off the bat, I'm putting fluids on board, ultimately so I can get the cardiac region to start taking this fluid and pumping it around. But they're going to fry their kidneys. They're going to be on dialysis the rest of their life. Right? And that's the danger to being in a low volume state. You're going to fry those kidneys. Now, based off of that, where in the kidneys do we absorb 60 to 80% of things? Where in the kidneys do we reabsorb 60 to 80% of things? Proximal convoluted tubule. Why? Samir. Why? Why do you think that's the region we reabsorb 60 to 80%? Closest to go back in the body? No, not exactly. Kathia?
It's the one closest to the Bowman's capsule, so it's the one that right at the beginning gets that.
Okay, so you said it's closest to Bowman's capsule, so therefore that's why it's 80%?
So I would just think you want to reabsorb it as soon as possible.
You'd want to reabsorb it as soon as possible. It would be nice. Maybe. Al? Well, oh, here we go. Philosophically speaking.
I have no idea.
Oh, good. Honest. Al has no idea. Most permeable to what? To the ions. Let me show you some basic vascular phys, and this will explain it all. If I turn around and say that these are the arteries, these are the arterioles, these are the capillaries, these are the venules, and these are the veins. As you know, we have protein in our vascular supply. We better. Otherwise known, the big one is called albumin. We have proteins inside the cells. We better. We produce proteins all the time. Who follows proteins or the highest concentration? Water. Water will always follow wherever I have the most concentration gradient. So think about this. If I have a lot of fluid in the arteries and I have proteins out here, just based off a dilutional effect, look at the way water is going to flow. Everybody understand? As I'm doing that, this is just normal vascular phys. Water at the arterial point starts to come out. Really, plasma, to be more specific, but it starts to filter out. As that protein is moving further down through the capillaries or to the capillaries, what's happening to the osmolarity? Increasing. Osmolarity increases, so by the time you hit the capillary beds, pretty doggone concentrated, isn't it? So then, post-capillary, what's the direction for water to move? Back in. Okay, everybody understand that? That's normal vascular phys. What if I take that same exact thing and I turn around and I draw, maybe the afferent side of the kidneys? Oh, it's actually Bowman's capsule here. Glomerulocapillary. Efferent side. Off the efferent side, running right along the PCT, proximal convoluted tubule, I have the peritubular capillaries. That's what they're called. Now let's think about this. You know, within the glomerulocapillary Bowman space, I filter fluid, correct? What do you think happens to osmolarity on the efferent side? What's going to happen to osmolarity? Has to increase. Has to increase. So when I get over here, shouldn't it look really concentrated? There you get your reabsorption, folks. That's why you guys were, Tamir and Kathia, you were kind of correct, but do you understand? Based off of osmolarity, pulling the fluid back, therefore that's why I reabsorb everything. Everybody understand? A little bit? Which one? This one here? Yeah. All right, so afferent side, I have blood coming into the kidney, right? I'm going to filter. As I filter, I should not filter protein. Do you agree? So I'm going to leave more protein over here. Isn't that what's happening over here? Yeah. Same scenario. When I get over here, it's very concentrated, therefore pulling water back. Well, that's what's actually happening here. So it gets over here. By the time it hits down to the peritubular capillaries, it's very concentrated. It'll pull from the PCT in. Technically what happens is it goes from the PCT to the cells. Well, let me back up here. Because osmolarity is so strong here, it pulls from these cells. Then these cells will pull from the PCT. You don't need that's a little further than what you need. Just know that it basically comes across. Everybody okay? Yes.
And then, but in the proximal convoluted tubule, that's also where you absorb the most sodium and most of the other ions.
But why?
Because it's following the water?
It's following osmolarity. It's a concentration gradient. Doesn't everything move across because of a concentration gradient?
But, yeah, I understand that. But if you have more osmolarity, the water is going to follow.
Absolutely.
Right?
But I understand what you're saying. So your point is why is it the ions are shifting also? You will pull ions over here also. You are correct. You're going to pull water, but ions will shift over here based off of a gradient because why? I'm also losing ions too during my filtration. So ions will come across. I have to replace those ions for normal cell function over here, and it'll pull those ions in. Okay. Everybody okay? Yes.
Why is it that we said during our low energy state?
Yes, during low energy state.
Why is it then that the proximal convoluted tubule is most susceptible to this?
Why is the PCT? Okay, well, remember, the two areas that I have in the cortex is what? PCT and DCT. So just based off of blood supply and all that going to the cortex, remember that ultimately those areas also require ATP. So if I have my pumps there requiring ATP, ultimately those are going to shut down. That's where I have most of that function occurring in the kidney, right? The PCT. That's why that's the most susceptible. Because it'll also affect filtration. It'll affect reabsorption. It'll affect secretion. And since that's where in the kidneys I basically have most of my function occurring, that's why that's the most susceptible. Yes, Matthew.
Still a little bit confused as far as the concentration. Like, concentration gradients, they go from they're going to go from high to low, right? So is the water going lower first, making that a low concentration before the...
You got it. Exactly. And it's a dilutional effect, therefore all the electrolytes will shift. You got it perfectly. So the question was, why I thought we'd go from a low concentration to high concentration. Water comes across, causing a dilutional effect, and ultimately your electrolytes are going to follow. Okay? Moving forward. All right, so sweat. Let's think about this for a second. Why do we sweat in different regions? I'm sure you guys have taken vacations. Maybe you went to the Caribbean. Maybe you went to school in the Caribbean. And when you get down to the Caribbean or some area closer to the equator, all of a sudden it's hot as hell. And you get down there and you're doing everything you can not to rip off your clothing because you're standing there in customs for hours to get through. So the same guy who's running customs is also probably the pilot plus the ticket agent plus they just change their hats. But yeah, I've seen it too. So the thing is that based off of that, why is it that you're so hot? And then you look over at all the people that are about to get on the airplane, and they're in sweatshirts. And you're like, what the hell's the matter with them? It doesn't make any sense. But by the time you're ready to leave, all of a sudden you're wearing a sweatshirt. You got whatever island you visited on your sweatshirt. Woo, yeah, all excited. And everybody coming off the plane is starting to sweat and looking at you, and now you're wearing your sweatshirt. The difference is, folks, when we go to hot places versus cold places, your nephrons change in size. They change in length. Now, what was the function of the medulla again? Concentrating urine. So think about this. I get off that plane. I am sweating like hell. Sweating all over the place. I need to reserve fluid. Do you agree? If I need to observe or reserve fluid, my nephron has to lengthen. And if it lengthens, I can reabsorb more water. You understand? How long does it take for your kidneys to respond? 2 to 3 days. So you're miserable for 2 to 3 days. Then all of a sudden you get up and you're like, whoo, today's a cool morning. No. The temperature hasn't changed since you've been there. You're just reabsorbing more water that you're losing, therefore being able to cool your body, sweat, reabsorb. But if somebody's in a hot environment and goes to a cooler environment, do you need to reabsorb water? No. So what's going to happen to your nephrons? They're going to shorten, so you're not going to reabsorb as much. That's the cool part about the kidneys. But think about this. Let's say you have a patient who is a renal failure patient or has decreased renal function. You see how dangerous it is for them to change climates? Because they cannot adjust, and you can put them in a low-volume state and make their renal situation even worse. That's a danger to that. But I think the kidneys are so cool because they can lengthen and shorten based off of what your body needs. That's what's so cool about them. Now, when we talk about the kidney and the nephrons themselves, if I'm talking about the afferent side, Bowman's capsule, the efferent side again, peritubular capillaries, and ultimately I have the PCT. Goes down, loops, DCT, distal convoluted tubule, loop, proximal convoluted tubule. Now what happens with the peritubular capillaries is it comes down here and starts to wrap around. And wraps around, on, and you get the point. And it keeps wrapping and wrapping all the way around. When it wraps around, we call that the vasa recta. Starts wrapping around, we call that the vasa recta. The vasa recta is a distal portion of the peritubular capillaries. That is the region responsible for ultimately taking in the water and concentrating the urine. Now think about this. If I turn around and have decreased blood flow to the kidneys, what portion of the kidneys are affected the most? The what? Medulla. But they can take it one step further and say, what portion of the medulla? Vasa recta. Okay? They can take it one step further and say the vasa recta, which is a distal portion, and that's responsible for collecting all the fluids and electrolytes. Okay? That's what happens. All right. So when we go from hot environment to a cold environment, those nephrons shorten, and vice versa. When you go from a cold environment to a hot environment, they lengthen, and it takes really 2 to 3 days, 3 to 4 days, right around that. And then ultimately, you can reabsorb more water. All right. Renal blood supply. This is a no-brainer on the boards, folks. Look at this. You know, or should know, that your aorta comes off and runs down the left side of your body. You should know that the IVC runs up the right side of your body. So the question was, on the boards, which side or which kidney receives the longest renal artery? Is it going to be your right side or your left side? If the aorta is running down this side, my kidney is real close to there, isn't it? But the right kidney is much further away. So the renal artery is much longer on the right. What about the IVC? Running up the left side, therefore the left renal vein has to be longer than the right renal vein. There were 2 board questions right there. 2 board questions. God bless you. Ooh, you better run like hell. That was wet. All right. Renal blood supply. Renal blood supply, when we talk about the right gonad vein, directly drains into the IVC. Right side is the most dangerous. So how can they ask you this on the boards? Well, if we turn around and we have the inferior vena cava, we'll say, so we'll call this the IVC. And I'll put the testes down here. Right testes, left testes. Right testes drains right into the IVC. Right into that IVC. The left testes drains right into the left renal vein. Right into the left renal vein. If I'm talking about suprarenal, isn't that the adrenal glands? Where does the right adrenal gland drain? Where do you think the right, Eros, where do you think the right adrenal gland drains into? Almost. It's going to go right into the IVC also. On the left, Eros, where does the suprarenal drain? You got it. Pretty easy. Now, everything on the right drains right into the IVC. Everything on the left drains right into the renal vein. So you now know if somebody has a problem on the right, it's much more severe. Why? Because there's more of a direct route. Lance Armstrong, right testicular atrophy, Mets to his brain, had it on the right. Now, on the left, can it get there? Yes, but it does take a little longer. It's got a longer path to go. So on the boards, they'll ask you what side would be worse, which situation would be worse, and ultimately anything on the right. Everybody okay with that? All right. Good. All right. Well, that was basically anatomy, and that's what they ask you on the boards for anatomy. That's straightforward. All right, so with the healthy kidney, no surprise, sodium and water removal. We should know that. Waste removal, and don't forget, the kidney has endocrine function. So hormone production, renin, as you know, for low volume state, erythropoietins if I need to make more red blood cells, and prostaglandins, which ultimately either dilate or constrict the renal vessels, and you know prostaglandins work throughout the body. Eros, what do they do in the GI tract?
I'm sorry, I was reading.
That's all right. So prostaglandins, what do they do in the GI tract or help with? Prostaglandins.
Relaxation.
Not absorption, not relaxation. How about not secretion? We're getting there. All right, we're on a roll here. So, okay, we got 3 knocked out. So in the GI tract, what's it going to do to the layers of the GI system? Especially the jejuni. Do we have something sitting on top of the microvilli? Anybody? Glycocalyx. Remember, you got the mucus and you have the glycocalyx, and prostaglandins are responsible for those glycocalyx, which is that protection. All right, so in an unhealthy kidney, fluid overload, all right? Elevated waste products, so urea, creatinine, potassium. Changes in hormone levels? Well, sure, I'll get changes in blood pressure. Making red blood cells via the erythropoietins, and the uptake of calcium would ultimately be affected because you know that, first of all, the distal convoluted tubule does take up calcium in that area. You also know that where do I get 90% of my calcium from to begin with? The GI tract. Thanks to the activation of who? Vitamin D. Is that 25 or 125? 125. Very good. 125. And it stimulates what enzyme in the kidney that's actually doing that conversion? 1-alpha hydroxylase. Therefore, that activated vitamin D goes to the kidneys and stimulates calcium-binding proteins. So ultimately, you reabsorb that 90% of calcium. Very good. All right. Now, with the kidneys, I have a different approach. I like to take the kidneys and I like to break it up into 4 quadrants. Because we got to look at insult of the kidney. Insult to the kidney. How do I know what part of the kidney is affected when there's an insult to the kidney? And by breaking it up into 4 quadrants, the tubules, the glomeruli, the blood vessels, and the interstitium. Interstitium, therefore, is the space between the tubules and the blood vessels. Same thing within the lungs, right? That's the interstitium. Interstitium is the space between those areas. Now, if I have an insult of the blood vessels, remember 20% of blood flow from cardiac output is going to the kidneys. 90% of it supplies the cortex, and I mentioned that already. 90% goes to the cortex. Now, only blood supplied to the medulla is a vasorecta. Vasorecta. So any decrease in blood flow, I'll infarct the medulla. Medulla, again, remember, is the first place in necrosis, medullary necrosis. So the point is that blood flow, any type of low-volume state, would ultimately destroy the medulla. And we beat that like a dead horse, all right? So, the glomeruli. How do I know there's an insult of the glomeruli? Well, consists of visceral epithelial cells. Remember, we talk about foot processes. What kidney disease do we talk about foot processes? Minimal change disease, right. So minimal change disease, we have foot process, or otherwise podocytes, glomerular basement membrane. Board question is type 4 collagen. Type 4 collagen. And parietal epithelial lines Bowman's space. Fantastic. But the fenestri, what is fenestri? Fenestri is you have your podocytes. Think of your podocytes as your fingers. And I'll put them together like this. And the space between my podocytes is your fenestra. That's the space between the finger-type projections. That's fenestra. And that should never change other than in minimal change disease. Otherwise, that should always be a standard. Most glomerular diseases are immunologically mediated. What does that mean? If I have a disease that is an autoimmune disease, would I expect the tubules to be affected? Would I expect the interstitium to be affected? No. I expect the glomerulus to be affected. So if they turn around and give you a situation where somebody has, maybe a nephritic or nephrotic syndrome, isn't it usually an autoimmune basis where it's destroying the glomeruli? Yeah. So if they turn around and give you protein loss greater than 3.5 grams, or if protein loss just in general decreased, I want you to always think of an autoimmune disease if the glomeruli is affected. Okay? And if you drop down, you'll notice on that list there's only one autoimmune disease on that list. But you want to try and figure out what's going on? Oh, hell no. Drop down, pick autoimmune, go. Get out of there. Now, if I turn around and change it to the tubules, don't we talk about cast? You guys have studied that, right? White blood cell cast, fat cast, red cell cast, cast. What is cast? It's a bunch of dead cells taking up the shape of the lumen of the tubules. That's all a cast is. And we'll go through what each cast means later today. But again, a cast is basically a bunch of dead cells that are taking up the lumen, or taking the shape of the lumen of the tubules. So proximal convoluted tubule, remember 80% reabsorption occurs there. Loop of Henle is where we have that triple transport, and we'll go through that. Distal convoluted tubule, and the collecting tubules for collecting urine, basically concentrating urine. So most tubule diseases are frequently caused by what? A toxin? Maybe a drug? When we say a drug is nephrotoxic, do we say that it attacks the glomeruli? No, it attacks the tubules. Don't we say eosinophil cast when it's drug-related? It attacks the tubules. If somebody's taking ethylene glycol, which is antifreeze, don't they get stones? Doesn't it affect the tubules? We don't talk about the glomeruli. So a toxin or a drug, I want you, if they say anything on there that the tubules are affected, drop down and either pick a toxin or drug on the list. There's only one there. Okay? And last but not least, the interstitium, which is the space between the tubules and the blood vessels. Again, toxin or drugs. Toxin or drugs. So in the cortex, comprising mostly of fenestra capillaries, so any change in this space, edema is abnormal. Shouldn't have any edema. And what is the first sign of cellular death? Swelling. There you go. There's your edema. Why? Because a toxin or a drug is affecting that area. If it's a tubules, toxin or drug. If it's a glomeruli, autoimmune. It's that straightforward, folks. You're going to see that these answers are just right there in front of you. You're just trying to look for the pathological disease associated with it and trying to answer it based off of details. Just quit doing that. I'm telling you, folks, I see a number of you walking around with other programs' books. And you know who I'm talking about. Quit flipping details looking at these thick books. I already told you, thick books are bad. Right? Be careful with that. It's clues and concepts.
Dr. Wolf,
Yes, sir.
so it seems like there's a thin line between tubules and interstitial.
Okay. So the thing is that, number one, they'll never give you both on the test. They can't. But if I turn around and you know that a lot of the cells within the kidney require ATP. So if I turn around and I affect flow, meaning a drug or a toxin, I'm going to affect the function of that kidney. Therefore, the interstitium is largely affected. And therefore, so let's say an example where I have even decreased blood flow. I'm not getting the ATP production from those cells because they're not getting the O2 necessary for glycolysis in a normal cell process. Therefore, that cell's going to die. So again, on the boards, if it's a toxin or drug, I want you to always either choose a tubule. That's usually the most common, is the tubule, or the interstitium, which is right alongside of it. It's going to be affected. Think about this. If I turn around and I have a cast in that tubule, all the cells that line where that cast is cannot absorb anything, right? Because that cast is there. So I'm going to also affect those cells that way just by mass effect. Okay? Electrolyte disorders. Electrolyte disorders. This right here in front of you is hands down my favorite concept. Dr. Francis' favorite concept is low energy state because you can tie it into so many different pathologies. Mine is cell death. You can tie that into so many different pathologies. It's a phenomenal concept that answers so many questions. Again, low energy state answers a lot, or you can tie every disease into that, and you can tie cell death into every disease. So some of this is a review, some of it we'll add to. Based off of what you have up there, the top left-hand corner, I have a normal cell, and every cell you should know has a sodium-potassium ATPase. Why? Because potassium can leak out of the cell. If potassium 50% is unbound, can leak out of that cell. The purpose of this pump is to pump against the gradient, therefore grabbing that potassium and pulling it back into the cell. The sodium that does get into the cell needs to be kicked out. That's why I have that pump, pumping against the gradient. To the bottom right of that area, you turn around and you see a sodium-calcium exchanger. Just think, for the purposes of cell death, that just sits dormant, okay? And it only kicks in when it's needed. Make things simple. We're going to look at the big picture here. So, based off of that, if there is some insult, decreased blood supply, ultimately that cell's not going to function properly. It's not going to get the oxygen supply it should, and therefore that ATP pump will shut down. If that ATP shuts down, that ultimately will leave sodium and some potassium in that cell. Who can freely leak out again? Potassium. Potassium freely leaks out. Who's left over? Sodium. Who loves sodium? Water. Water will leak in, therefore causing the cell to swell. Isn't that the first sign of cellular death? This is why. So that cell will start to swell. The cell does not like that. It will try and fix that situation. How? Sodium-calcium exchanger will turn on. When that sodium-calcium exchanger turns on, it's going to be pulling the sodium out. It's going to be pulling the calcium in. Anybody see a problem with that? It's a 2+ exchanging for a 1+, making the cell more positive. Now that calcium is inside the cell, I know that cell's more positive, more likely to depolarize. Everybody understand? All right. So let's see if you really understand. All right. So, Eros, you get your boards back, 245. You feeling good? Amen. All right. Al, you get your board scores back, 245. 246. All right. Oh, I'm sorry, I misspoke. Right, okay. 246. So you're going out to celebrate. Both you guys are going to go out on campus here. Go find yourself a little honey. Right, Al? It's been a while, you said? So, yeah. So you're going to go out. You're going to celebrate. You're going to be on campus. Well, you know there's going to be some lawyers in the bar. You just know it. And you guys are ranting and raving, and the girls are jumping up and down. Oh, they're here, and they're all excited, right? And all of a sudden, there's a couple of lawyers on the side, and they're upset because the girls are no longer paying attention to them. Oh, you're just lawyers? The doctors are over here. Woo! Yeah, this is where the cash is. I'm hanging out here, right? Yeah, those are the girls you want, right? Yeah, sure. So ultimately, they start making fun of you, the lawyers. We can't have that, can we, Eris? No way. Absolutely not. Can't have that. So you're going to go over there, and you're going to talk to them, right? Yeah. You guys been drinking, got your beer muscles? Woo! Yeah. You can go over there and you're going to talk to them. And the lawyer's going to confront you. So what do you have to do? What do you have to do, Eris? Knock out their ATPases. Absolutely. What? So you're going to get in a little scuffle, and you're going to turn around, and you're going to punch that lawyer. And when you punch him, what happens? Outside of being sued, what happens?
Nobody goes home with the girl.
Nobody goes home with the girl? Okay. So you must have been in a lot of fights. No. I'm kidding. All right, so yeah, you're going to hit that lawyer, and he's going to hit the ground. You're going to look at him, and you're going to laugh a little bit. What's the first thing you're going to see? Swelling. So when I turn around and I hit that face, and I turn around and I create a spasm underneath that skin of those blood vessels, Therefore, those cells are not getting the supply of blood it needs, and I'll shut down that pump. So you mean that cell starts to swell? And if you stand there a little longer out and you stare at him, what starts to happen to that area of his face? It starts to fasciculate, doesn't it? It starts to twitch. Isn't that more likely to depolarize? Yeah, that's what happens. I'll give you another scenario. Let's say there's a situation where there's, I don't know, maybe a soccer player from England and his wife who come here to the United States who get paid way too much. And he comes into your office with this knot on his leg. And during a game last month, he was kicked. Think about this for a second. If I turn around and I kick the side of somebody's leg, and I cause a spasm of those blood vessels, if the trauma is significant enough, I'm going to basically destroy those cells. How? Because first you're going to start to get cellular swelling of that area. Calcium's going to come in, you're going to start to get those fasciculations. But calcium will not leave as long as that pump is off. All of a sudden now he starts to get dystrophic calcification in that area, and now you have calcium build up in that area. That's what happens. But wait a second. Let's say you turn around and you celebrate, you're all excited, and you get in the habit of binge drinking. And I'm binge drinking, and my triglycerides are going up through the roof. Wouldn't that increase your osmolarity, your vascularity, making things more viscous within your blood? Decreasing, I don't know, maybe blood supply to the area of the pancreas? If I decrease the blood supply to the pancreas, will I get dystrophic calcification? Yeah. And don't we call that saponification? Yeah, that's what happens. It is such an awesome, awesome concept because I can turn around and explain so many things. Let me ask you this. If I turn around and look at the brain, and there is something in that brain tissue that should not be there, want to create a mass effect? Want to push on the blood vessels in that area? Won't it calcify around that object? Don't we call that ring-enhancing lesions? Oh, but we're so excited when we read a vignette. We go, oh, ring-enhancing lesions. Does that tell me anything? No, it doesn't tell me a damn thing other than something is there, decreasing blood supply, and destroying the tissue in that area. But we're so excited when we see ring-enhancing lesions. Anything up there causes ring-enhancing lesions. But we use it as a clue all the time. Oh, yeah, this is good. No. It's just something that's causing a mass effect. That's what's so exciting about this. Let's see. Let's flip it around to a drug. Is there a drug that shuts down that sodium-potassium pump? What? DIG. DIG shuts down that sodium-potassium pump. Why is it, Al, then, we do not get dystrophic calcification? If it shuts down the pump.
Maybe it doesn't shut them all down.
Doesn't shut them all down? Okay, kind of, but a little more specific. Anybody? Elizabeth? Because of the half-life of the drug. Because what did I tell you? How do I get calcium out of that cell? That sodium-potassium pump has to turn back on. If I have a half-life of a drug, it comes off. That pump will turn back on, changing the gradient. Ultimately, I won't get dystrophic calcification. It's a cool concept. Every time somebody has cellular injury somewhere, they will calcify if the injury is significant for an extended period of time. You get calcifications. You guys wonder why you have knots in your legs or whatever based off of an injury or something that happened or on your hand? It's calcified tissue. Why? Because of this process. You can go through all kinds of injuries of the body and explain dystrophic calcification throughout the entire body. That's what's so cool about it. All right? Everybody understand? All right. Good. All right. So we get a patient that presents with polyuria, polydipsia. Polyuria, polydipsia. Polyuria, polydipsia. What's at the top of your differential list? Diabetes should always be at the top of your differential list. Polyuria, polydipsia. But then you run a glucose, and it's normal. What's the next on your differential list? Two possibilities. What are they? Right? Diabetes insipidus and psychogenic. Psychogenic is when somebody's drinking too much water. How do I know somebody has psychogenic? How can I, based off of a history, find out they have psychogenic is ask them how much water are they consuming. You know those water jugs at those coolers, the big plastic containers that they have out there? Think of those containers, and these individuals will drink 10 to 15 of those a day. Yeah, and you're trying to get through 8 ounces or whatever or bottles, and you're crying that it's way too much? Yes, gallons. Yeah, damn right. So, absolutely, a good way to piss off the water, man. Right, because he's got to keep coming back. Because basically, that is a crap load of water, isn't it? Let me ask you this. With those individuals drinking that much water, do you think they're voiding a lot during the day? Oh, yeah, half their day's in the bathroom or behind the bushes outside or wherever. Half the day they're urinating. So, this patient comes in, polyuria, polydipsia, glucose is normal. What is our first step in management? What's the first thing we're going to do? Stop water? Well, okay, so we'll make it a little more basic. We admit them to the hospital, right? And then we do a baseline urinalysis because we have to compare it. If we have to do any intervention, we have to base it off of that baseline. So I turn around and do a baseline UA, and then our next step in management is what? What's our next step? What is it? Don't be shy. Stop water? So restrict water? Sure.
And have
So
someone watch it.
have some. Ooh, okay. Great. Nurse Jane, sit down and watch this patient all night. So we just put them on EKG monitors. We're not that torturous.
No, because I just remember that there's a high risk that they'll drink from the toilet.
They'll drink from the toilet. Yes, well, if they have a bathroom in their room, absolutely. You put them in an isolation room. So basically, think about this. You're correct. They will drink from the toilet if they have access to it, no matter how disgusting that sounds, especially being a hospital toilet on top of it. But listen, if I turn around and I have this patient admitted to the wards, and I turn around and put him in an isolation room, and I restrict water for 24 hours, you better hope you're not on call. You better hope you're not on call. If you have a partner who you absolutely hate, hopefully they're on call that night. Why? It's benign, restricting water, isn't it? Let me ask you this. If you restrict water, has their voiding hygiene changed? No. No. Will they get severely dehydrated in the middle of that night? Absolutely. Will they have arrhythmias? Will they code? Yeah, absolutely. So we usually stop the test as soon as we start to see arrhythmias. We don't run the full 24-hour water deprivation test. Even though that's what we call it, we don't, especially if it's psychogenic. And if they turn around and concentrate the urine, and the urine starts to concentrate at that point, and we know it's psychogenic, call the nuts, right? Call the psych unit, because that's what your patient has to go to. So, based off of that, let's say I have that patient come in, who comes in, polyuria, polydipsia, glucose is normal. You assume it's psychogenic. You admit them. You do a baseline UA. You restrict water for 24 hours, and their urine is still dilute. What are your two possibilities? What are your two possibilities then? Diabetes insipidus central versus nephrogenic. One's in the brain, anterior or posterior pituitary? Posterior pituitary ADH. The other one is in the kidneys. What part of the kidneys? Collecting ducts, most specific, the principal cells of the collecting ducts. So think about this for a second. If I turn around and have this patient who comes in who has polyuria, polydipsia, glucose is normal, admit them, baseline UA, turn around, restrict water for 24 hours, no change, I'm down to central or nephrogenic. What's our next best step in management? Give them vasopressin ADH, which is a synthetic ADH. If I turn around and give them that synthetic ADH, I always think of ADH as a very stupid hormone. Why? It'll work whether it needs to or not. If it is present, it will work. If it is present, it will work. God bless you. If it is present, it will work. So if I turn around and I push vasopressin on this individual, and their urine does not concentrate, what's your diagnosis? Nephrogenic. It's a receptor problem. Because they have ADH, it's just not working. However, if the urine does concentrate, what's your diagnosis? Central. That's all it is. That's how you calculate diabetes insipidus, psychogenic, versus glucose, diabetes. Okay? So the next page, I actually have it all in a chart form for you. We just walked through this verbally. And again, it's all there for you, everything we just said. Okay? So psychogenic, remember, has too much, anywhere between 10 to 12 gallons. Central, remember that I know it's the posterior pituitary. And nephrogenic, I know it's a receptor problem. Okay? And vasopressin, ADH. All right. That's the big one there. Yes? What? So your question is, if I have a psychogenic patient or a patient who has psychogenic polydipsia, polyuria, all that, how is psych going to help them? Any future psychiatrists here in class? Okay. Well, to them, it will help. To the rest of us, you get my point? All right. Yes. Absolutely. So the question is, how does thiazides work with nephrogenic diabetes insipidus? And you would think, well, wait a second. If this person's urinating a lot, then ultimately, why would I want to give them a diuretic? This is where we give the diuretic not for its mechanism of action, but for its side effect. Now you're going to SIADH. Now we're going to, well, remember, you just went for nephrogenic, though, right? That's not SIADH. Nephrogenic means it's a receptor problem. Do you agree? All right. So is there a drug that can cause that? Lithium. Lithium's notorious. Once I knock out that porin, I have to produce more. Okay. And it takes time. But the side effect of thiazides is that they stimulate porin production. So, yes, it causes them to urinate more, but two things happen here. Number one, does diuretics work on water or sodium? What do you think? Sodium, and therefore water will follow. God bless you. Sodium and water will follow. But if I start losing a lot of sodium, the body won't like that and will start hanging on to that sodium, right? Low volume state. Also, thiazides will stimulate new porin, so I'm making new water channels. So you see how it does two things at once, and that's why we use that for nephrogenic diabetes insipidus. Yes? I'm sorry? Okay. Class, if I have a person on a drug that's causing a problem, what's that first step in management? Stop the drug. Stop the drug. Okay. What do you mean? So if somebody takes a drug last night and they come in with nephrogenic diabetes insipidus, is that what you're asking me? Well, just basically also there's a half-life of drugs, right? So I'm going to go ahead and wait that out and see if the body will compensate. If it doesn't, then I have to intervene at that point, and I would consider a thiazide, which is a drug. Realistically, I can also use potassium sparer. Works in the same area. I won't go into that right now, but basically, if somebody comes in with a toxicity based off of knocking out receptors in the kidney, let's see what happens first. Okay. Just polyuria, polydipsia doesn't mean anything because I can keep that patient hydrated and buy some time on the wards. Right? Okay. All right. Fluid replacement. Fluid replacement. This is one of the ones where I shifted a couple slides. When you have a burn patient, we have something called the Parkland formula. Folks, there's a couple different formulas out there for burn patients. Parkland formula is just one of them that the boards actually likes to use. Will you get a lot of questions on this? No. It's more conceptual than actually the calculation portion of this. And as I told you before, if you're doing a calculation question on the boards and all of a sudden you find yourself in long division, stop. Stop. You are wrong. You should be able to count on your fingers and answer these questions. If you're from the South, maybe you have to take off your shoes, but you should be no, I'm kidding. Come on. All right, so ultimately, you should be able to count your basic digits to answer these questions. All right, so burn patients, Parkland formula. All right, so to calculate the deficit, we use 4 cc's. 4 cc's. Now, if you look, sometimes some books say normal saline. Technically, the Parkland formula was designed for lactated ringers. Where do we turn around? What's the difference between normal saline and lactated ringers? More colloid solutions, like your electrolytes and things like that are in there. What kind of patient do I, outside of burn patients, what kind of patient would I normally, what service in the hospital uses lactated ringers all the time? Surgery. Surgery. Why? Why? Because why? Lactic acid? When you're not moving, so you get lactic acid when you don't move. So then by, 4 o'clock today, you're all going to have lactic acid? You are? So, Al, you got a lot of problems. So, but it can be worked on. All right, Al, think about this. I have this patient here. Lay it on the surgical suite. On the table. You got your knife, your shiny knife. When I start cutting, I'm destroying those cells. Won't those cells release electrolytes that I'm cutting? So I basically need to replace those electrolytes of the cells that I'm also ultimately losing within the blood and things like that. Okay? So that's why lactated ringers is real common in surgery. Now, based off the Parkland formula, ultimately lactated ringers or normal saline, whatever one you want to use, they won't have you differentiate between the two. But technically, I've seen a lot of, the board questions, I've seen them throw normal saline, and that's not technically right. It's lactated ringers for the Parkland formula. Just be aware of the difference. They'll never have you differentiate between the two. Based off of that, I take 4 cc's, I multiply it by the weight in kilograms, by the percent of burned area of that patient. Never calculate more than 50% of burned area. Let me explain what that means. If somebody has a 2nd and 3rd degree burns, that's what we use the Parkland formula for, not 1st degree burns, 2nd and 3rd degree. And let's say they come in with 80% of their body burned. You do not pump 80% in the burned area in that calculation. You stop at 50%. Reason is the body will never lose more than 50%. It will never lose more than 50%. This is how you get the questions wrong on calculations. Never, ever exceed more than 50% on your calculation. Ever. Ever. Now, replace fluids. How do I replace fluids? Once I do my calculation, and I'll have an example here in a minute. Once I do my calculation based off of the replacement of fluids, let's say I have an X amount of fluids I have to give half of those in the first 8 hours. The remainder of the fluid left over, the other half, I give over the next 16 hours. Now, this is where they'll get you on step 2 and step 3. It is from the point of trauma that the clock starts. So if it is 4 hours before you start intervening, you do not put half the fluids in 8 hours. You put half the fluids in 4 hours. So it's from the point of trauma. That's why when the paramedics bring a patient into the ER and the ER attending says, when did this happen? Now you know why. If it is a burn patient, it's very crucial to know what point did this happen at. Okay? So again, from the point of the trauma. Now, when it comes to the percentages, how do I know what percentage? Folks, in the real world, your palm, outside of the palmar crease, your palm is basically 1%. 1%. So in the real world, if you had to calculate real quick burned area, you kind of know that. If you want to calculate even faster, they have these percentages. Head and neck, 9%. Each arm is 9%. Front of the torso is 18, larger area. Back of the torso, 18. Each lower extremity is 18. Why? They're pretty large in an adult. And genitalia, 1%. So now for newborns what? They look like Mr. Potato Head, don't they? That's what newborns are. Mr. Potato Head. Therefore, subtract 9 from each lower extremity. Why? Because they're small. And then just add it to the head and neck. So 27 for the head. So the bottom line, again, these are just percentages. Yes, unfortunately, a lot of this is rogue memorization. You can do a little cartoon and write the percentages in there. Doesn't matter. Again, if they give you a burn patient over 50%, will you use that number or will you use 50%? 50% in the calculations. Do not exceed that. All right, so let's look at it in a question. This is something I just put in a slide you don't have. I'll slow down so you guys can copy this if you want, but I think more important, just listen first. A 36-year-old firefighter at 70 kilograms was trapped in a burning building and suffered second and third degree burns to over 65% of his body. What will be the fluid replacement management? Now, how do I know what fluid replacement management is? Your urine output should be 1 cc per kilogram per hour. Actually, there's a range, a half a cc to 1. But now I'm talking about a burn patient, so I want to take the higher end of the range. So I always stick with 1. 1 cc per kilogram per hour. So if I turn around and I have a 70-kilogram man, he should be putting out 70 cc's an hour. Okay, everybody understand that? Based off of the kilograms. So I take the 70 kilograms of this patient, which they told us. He burns 65% of his body, and we're going to stop at 50. So I multiply the 70 times the 50, gives me 3,500. Everybody understand so far? Then remember, it's 4 cc's. So I take the 4 cc's and multiply it by the 3,500, gives me 14,000 milliliters, otherwise 14 liters. And how much do we replace in the first 8 hours? Half. So I give them 7 liters within the first 8 hours. I give them the remainder 7 liters over the next 16 hours. Everybody understand that? Now, day 2 post-burn. If we were giving them 14, now we're going to give them 7. And we give it to them throughout the 24 hours. Day 3, you do absolutely nothing. Because think about this. Let me ask you this. A burn patient. How many of you have ever seen a burn patient, second or third degree burns? All right, so a number of you. Let me ask you this. When the squad brings them into the ER, and it's pretty close to the insult time of injury, they look normal, don't they? Maybe a little red, maybe a little bit of peeling skin. If you come back 6 hours later, can you identify that individual? No. They look like the Michelin Man. They're just swollen, their face, depending on what area is burned. They can have circumferential burns, eschar of the skin, things like that. That brings up a good question. If somebody has a circumferential burn and has compartment syndrome due to that, what do? Cut them open. Right. Eschar, just start cutting in 4 areas. But do I have to clean that area first? No. It's already destroyed. It's already dead. Those cells are destroyed. So again, based off of that, you go ahead and cut. Now, day 3, you do nothing. Why? Because day 1, they had all that edema, didn't they? Did they lose the fluid, or did it just go somewhere else it shouldn't have been? Just went somewhere else. It should not have been. Now I'm putting fluids on board to fill those pipes. But the fluid that was already in those pipes are in the interstitial tissue. Do you follow so far? So on day 2, that's why I'm giving a little bit less, because they don't need as much. Day 3, they have massive enuresis. Massive amount, because they got to start getting rid of that fluid because the edema is starting to come out of the cells. You understand? All right. So let's look at another question. So urine output, as I said, was 1 cc per kilogram per hour. And let's say we have a 70-kilogram male. How much should he be kicking out every hour? 70 cc's an hour. Based off of that, what if they give you patient A and they say that his urine output is 15, 20, 15 an hour? What's your next best step in management? What's your next best step in management? It should be 70, shouldn't it? So what should you do next? Right, give them more fluids, because that's the problem. Give them more fluids. Patient B, 300, 250, 270. Urine output. What's your next best step in management? Decrease the fluids. Patient C. Over the first 48 hours, urine output has been between 50 and 100 milliliters an hour. Well, that's within the normal range of where he's at. Now on day 3, urine output is 250, 300. What is your next best step in management? Nothing, because this is the massive enuresis that he has. That's it. That's as hard as the Parkland questions get. That's it.